Okay, so I'm just going to give it a minute for folks to file in, and then I'll make some announcements.
Great.
Okay, welcome everyone. Hello, my name is Rachel Hasna, and I am with UNM's Division for Community Behavioral Health. Welcome to our Law and Mental Health Didactic Series. A couple of quick announcements about our CEU process. In the last 5 minutes of the webinar, we will be submitting the link to the evaluation in the chat function. So if you toggle the bottom of your screen, a menu should come up and you hit that chat icon and you should find the link there. You'll want to copy and paste or click on the link, fill out the evaluation, and a certificate is automatically generated for you. It is your responsibility to save a copy of this certificate. So if you're on your smartphone, you'll want to take a screenshot. And if you're on your computer, you just save a copy of the document. If you're joining us by phone, you can send me an email and I will get you the evaluation link. This is being recorded, so later this week or beginning of next week, you should receive an email from me with the recording link as well as the PowerPoint. So, and if you have any questions for the presenter, the Q&A function, submit your questions there, and I'll hand it over to Julie.
Thank you, Rachel. Welcome everyone to the University of New Mexico Law and Mental Health Didactic Series. This series is hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Services Division. We're so glad to have you all here to join us today. My name is Julie Bravko. I'm an assistant clinical professor in the Department of Psychiatry and Behavioral Sciences. So first, I want to announce that we are accepting applications for our forensic postdoctoral fellowship. We do have 2 spots available for the 2021-2022 year. Our brochure is ready to go and applications are due on January 14th. Email me if you'd like a copy of the brochure. Next, I want to remind you to join us next week. At that time, Terry Cougar is going to be presenting common errors and what to do about them in forensic evaluation. For our talk today, we will be holding questions until the end. Please ask them in the Q&A anytime you feel comfortable, but just know we're not going to get to them until the end of the talk. Also, we always try our best to get through as many of your questions as possible. Please forgive us if we can't get to yours. And next, for those of you who want your CEUs but are on a tight schedule, you do have to stay for that full hour, but you don't have to stay longer than that. So I'll try to remember and let you all know when the hour has passed, but just know we will likely be staying on longer to address questions. Now it's time for what we've all been waiting for. I'd like to introduce to you our speaker for today, Dr. Casey LaDuke. Dr. LaDuke, I'm going to go ahead and turn it over to you, but thank you so much for being here. We really appreciate it.
Thank you, Dr. Bravko, and thank you everyone who made the time today to join for this conversation on neuropsychological considerations in forensic practice. My aim here is to be as helpful to you as possible and to give you some helpful and practical tips to improve your practice and handle neuropsychological considerations when they come around. So thank you very much to everyone here, as well as our hosts. This is a great program, and I've benefited so much from it. I'm excited to be able to contribute back. And this is the topic for today, neuropsychological considerations in forensic practice. I am your presenter, Casey LaDuke. I'm at the John Jay College of Criminal Justice and the Graduate Center. Both of those are at the City University of New York. And it's worth noting that I have no financial relationship to this program. All the views I'll be expressing are my own. And do not represent the views, policies of the University of New Mexico. So I am giving myself a brief bio here so that for the rest of this conversation today, you have a sense of where I'm coming from, where my experience in neuropsychology and forensic practice are. And I have selected to use the Christmas colors here. I have Christmas to this slide. As homage to our UNM hosts. It's also the season of Christmas, so it seems fitting. And everything in red, even if you're not reading the actual text, you can easily see that there is plenty of forensic focused training and experience throughout my trajectory so far. In green, there is all the neuropsychology training and experience. So I got training in both forensic and neuropsychology at Drexel University during my PhD. On internship, I focused mostly on neuropsychology while also maintaining research productivity in some forensic aspects. Postdoc is a big deal in neuropsychology and in formal neuropsychological training. I did mine at the University of Virginia Health System and Western State Hospital, as well as some experience at the Institute of Law, Psychiatry, and Public Policy, all within UVA. Now, for the last few years, I've been at CUNY, the City University of New York, and my primary position is at John Jay College, which is known in the field of forensic psychology. So I'm kind of the forensic or the neuro person out of a forensic program. I'm on the core faculty for the doctoral program there as well. I'm also an associated faculty in the doctoral program at Queens College, which is focused on neuropsychology. There, I'm the forensic person in the neuro program. I am a volunteer assistant clinical professor at the Brain Injury Research Center at Mount Sinai, where we're focusing on how we can increase access to the best in brain behavior science for people with traumatic brain injury. I do some service with APLS, with the National Academy of Neuropsychology, Law and Human Behavior, and the Journal of the International Neuropsychological Society. And I'm in private practice in all these areas as well in the New York metropolitan area. So I'm presenting this to you again, just so it's a snapshot where you can see, as I'm speaking about these, I am pulling from both what I know about forensic psychology and what I know about clinical neuropsychology. I'm not holding this out as something you need to do to practice in this area. I do not think that this is necessarily a model to use. I just wanted to make it known kind of when I'm saying things, where I'm pulling from. Happy to answer any questions about any of this as well, but I think that's enough about me, and let's get into the content here. And before I move on, I want to have another unofficial disclaimer. The views expressed in this presentation are both mine as well as those of some amazing people I hope that you all will take a look at. These are my collaborators. These are my supervisors over time, and they have been instrumental in setting my ability to understand and talk about these concepts we'll be talking about today. So Chrysalin Tussey is in private practice in New York City. Beth Arredondo is in hospital practice in Louisiana. Scott Bender and Bernice Markopoulos are both affiliated with the University of Virginia. Bernice also works at James Madison University. And then they all work in private practice here and there as well. So Everything I'm saying is, if I sound like I know what I'm talking about, it is because of these individuals and more. So please do keep that in mind as we move forward. The 5 of us are currently drafting a chapter for the forthcoming Oxford University Press Handbook of Psychology and Law that's being edited by Dave DiMatteo and Kyle Scher. So if this is of interest to you, then there'll be an opportunity to grab that in hopefully the next year or so. And some basic definitions here are for if we're talking about neuropsychological considerations in forensic practice, we should probably identify what I'm talking about. Neuropsychology, broadly defined, is the study of brain-behavior relationships. It's focused on the intersection of brain and behavior and is in the assessment and intervention and advocacy roles that we serve. That is the focus of the field of neuropsychology. As we all probably know, the field of forensic psychology or forensic practice is at the intersection of behavior and the law. Again, it can focus on assessment and intervention, advocacy, and many other roles. Today, we'll mostly be talking about forensic mental health assessment. Forensic intervention could be a whole other talk when it comes to neuropsychological considerations. But today, let's just focus on assessment. And why are we even doing this? So to set the stage a little bit, I think it's worthwhile looking at a few pieces of literature that are kind of showing us the importance of understanding neuropsychological considerations in our work. This is a publication a few years ago in 2016 by Nita Farahany, and it is a review of criminal opinions between 2015 and 2012, in which neurological testing is discussed. And looking up top, you can see the purple line is interview plus, green line is scan plus, everything is going up, and the interview plus and scan plus are at the top. It's interesting then to note that the definitions of these sure sound a lot like neuropsychology and neuropsychological practice. They are packaged here as neuroscience, or neurobiological evidence. The actual definitions that they use, though, are neuropsychological testing and evaluation, along with some scans, neuroradiological evidence. But this sure seems like it's saying neuropsychology is having an increasing role in criminal opinions, at least those that are captured in this study. And the prevalence of neuropsychology in criminal law is not just increasing, it's also having a significant impact. So this is from the same publication showing us the degree to which the evidence described on the last slide is being discussed in these opinions. And it's not just mentioned, it's not somewhat discussed, it is a substantive part of these opinions, showing us that it's not just there, but it's also being used by these courts to make some decisions here. And you might be thinking, all right, but so are we. We're doing this as well as forensic psychologists. This is some work a few years ago by Paul Kaufman. He's a board certified neuropsychologist as well as a practicing attorney. And he was looking at the same databases. So these criminal opinions in the LexisUni, LexisNexis, it has many names, databases. And what we can see here is that neuropsychology, the mention of neuropsychology is outpacing mentions of forensic psychology, forensic psychiatry, and neuropsychiatry in these cases. Using some regression modeling, they are also predicting that these are all going to go up, and you can see forensic psychology and neuropsychology are going to go up quite a bit. So this is likely the tip of the iceberg. What we know about the types of cases included in what was reviewed for this work, they are appellate decisions and typically are only included if they are notable for certain reasons as well. So they do not represent all of the cases that we are likely working on. However, typically these are classified as like tip of the iceberg, suggesting that the pattern is likely similar, but the amounts are likely higher. So on that backdrop, we have a legal system that's increasingly turning to neuropsychological evidence to help make its decisions. And as forensic psychologists working in that field, it makes sense that we might want to learn how to identify neuropsychological considerations in forensic mental health assessments, our own forensic mental health assessments. It might be worthwhile to know the general and specialty competencies that go into neuropsychological practice and know how then to best respond to referrals we have where we're identifying some neuropsychological considerations. Those are some foundational aspects here, and they seem like worthwhile learning objectives. That's what we'll be focusing on today. I will be starting at the end. Here is a proposed model for responding to forensic referrals with neuropsychological considerations. You can see here that the general model that we'll be building together today is first based on questions of relevance, and these are relevance for the assessment itself. The next step, once we determine relevance, would be competence for the practitioner, for us. The second step is more inward facing and questions about our own competence in these areas. And here we have a simple, flexible breakdown of the questions that you might ask, and given the answer, what you might choose to do with that referral. The outcomes most likely being independent evaluation, seeking consultation, or referring out most likely to a neuropsychologist. So again, this is a model that we'll be building together throughout our time, and we will be focusing then on relevance first. The first question that we would want to ask ourselves, let's say hypothetically, you are a forensic practitioner or a person in training who wants to do some forensic practice in the future, and you get a referral that has potential considerations in the area of neuropsychology. What do you do? Well, the first thing you ask is, what are these considerations? What counts as a neuropsychological consideration in these referrals that we get? Well, in my view, there are a few ways to think about it. Most relevant would be clinical considerations of a neuropsychological nature, practical considerations, and actually doing this evaluation. Do I feel like neuropsychology will come into play? The practice of neuropsychology might come into play. And legally, are there precedents? Are there case laws? Is there a legal foundation that I need to be aware of that might impact this beyond what we typically cover in our forensic practice, including neuropsychology as well? So again, what counts as neuropsychological consideration is a valid question, and one I think it's going to take a little while to go through. So first, let's focus on these clinical considerations. This slide and the next two are based on work that I have done scouring the literature of forensic neuropsychology specifically, as well as neuropsychological literature focused on forensic aspects, as well as forensic literature focused on neuropsychological aspects. Basically, I've looked at a lot of things and I've tried to see what is brought up most, what's brought up frequently, what tends to be included, and I've put them all on this slide here for you. Feel free to take snapshots, to take notes. You will have access to these slides later if you find this helpful. These are the main clinical disorders that would be considered are more likely to come up in forensic referrals that would be considered neuropsychological in nature. So in terms of the kind of big hitters, traumatic brain injury is very frequently discussed in the literature as a highly forensically relevant neuropsychological consideration, one that you'll likely see included in your evaluations. Dementia and neurodegenerative disorders, also with the aging of the criminal justice population, the increasing numbers of those with dementia in the United States, which is supposed to triple, by the way, between now and 2050. Dementia is certainly something that we are seeing and will likely see much more of in the next few years and decades. Seizure disorders are another significant neurological illness that has forensic implications, and therefore referrals relating to epilepsy and other seizure disorders are likely. Injuries from neurotoxins, external substances that have a direct impact on the central nervous system, certainly are in the civil realm. A common referral question may come up in criminal referrals as well. Substance use is such a pervasive consideration in forensic psychology. It's one that we all know quite well. The lens of neuropsychology and substance use disorders, how they impact the brain and how that impacts our behavior, that would be kind of bringing it more into the neuropsychological realm. And then psychiatric illnesses are worth discussing as well. Another area that, as forensic psychologists, we have a lot of exposure and experience with. Again, taking a lens of neuropsychology would say, how do these disorders affect the brain? How does that come out in our cognitive tests? And therefore, there are some that are likely to be considered through kind of a neuropsychological lens in forensic work. Psychotic disorders, specifically schizophrenia spectrum disorders, are likely to come up quite a bit here. Also, the major mood disorders like bipolar disorder, major depressive disorder, post-traumatic stress disorder as well. So the rest we can read on our own. The main ones are they're kind of listed in order, but of course, farther down the list are other clinical considerations that we as forensic psychologists know quite a bit about, something like intellectual disability. Again, this slide is showing us that these are things that can be placed quite easily in a neuropsychological framework, and therefore that might drive you to call these a neuropsychological consideration. Take a quick break and let us finish up reading over this slide before we move on. It's interesting to think that each of these in and of themselves could represent a presentation in this series, right? A deep dive into traumatic brain injury, a deep dive into epilepsy is worthwhile when we are thinking about how we're going to even respond to referrals and incorporate these considerations into our practice. What we're trying to do here is give more of an overview. If there are specific questions, however, the question and answer time is kind of designed for us to be able to dig in there. Please feel free to ask your specific questions if you do have them about any of these clinical disorders. So beyond the clinical disorders that may be part of the referral questions we're getting, there are some other practical considerations we would want to consider. These are, in the practice of this assessment, will I need to pull on neuropsychological skills here? Will I need to conceptualize this case in a neuropsychological lens? And training and board certification is certainly one of those, of meaning your own training and any sort of indicators of competence that you might have. The roles of forensic psychologists in neuropsychological assessment, more broadly speaking, identifying referral questions involving neuropsychological considerations and responding to those are also important practical considerations. That is what we're talking about today. Those top four should sound pretty familiar. Those are where we're starting today. Other considerations, though, in how you choose to respond to these referral questions may include practical considerations like formulating referral questions to neuropsychologists if you are referring this case out. You also may be evaluating neuropsychological data from other experts in the case. So being able to evaluate those reports would certainly be worthwhile. And then we get into the more foundational aspects of all assessments, but these assessments in particular. So scientific foundations of our work would include psychometrics that are important to the assessment of the various neuropsychological constructs we're dealing with here, and conceptualizing them in our impressions, diagnostic considerations, and recommendations. Cultural considerations are incredibly important, being appropriately responsive to the various identities held by those we're working with, knowing how individuals with these identities are captured or not by the tests and norms that we're using, incredibly important in this area. And then there's ethical considerations and cognitive biases and heuristics, things that have been covered in this seminar series very well. And very specific to neuropsychology is a flexible versus fixed battery approach. That's a historical consideration in the field, and one that does still come up in practice. Performance validity, third-party observers, release of raw data, and communication of findings. Those are, again, things that we know about in forensic practice. Putting a neuropsychological lens on it, though, may raise it to the point that you don't feel comfortable taking on that evaluation yourself. Interestingly, it's worth pointing out performance validity here as a unique contribution, a significant contribution of neuropsychology to the field in general, to clinical assessments in psychology in general, letting us know the importance of assessing performance validity throughout our assessments and giving us the tools to do so has been a significant contribution from this field, and one that we're now all much more aware of because of it. Take another break here, finish looking through these, and again, just these are considerations that may not appear neuropsychological on the face of them, but when you are a practicing neuropsychologist, these are the types of things that come into play for our assessments, and therefore may come into play in any forensic referral that you're considering as well. Also, these are frequently discussed in the literature around forensic neuropsychology and forensic practice and neuropsychological practice. So these should not be new necessarily. However, naming them and centering them as neuropsychological considerations can be helpful if you are forced with making some decisions. So that's really the contribution here. And the same goes with this slide. So where we are likely to see referrals in our forensic practice is dictated by some legal considerations as well. And you would want to consider these when reviewing referrals. The types of psycholegal questions that we're being asked to answer, we're most likely to see neuropsychology coming up in competence, in criminal as well as civil law. In criminal law, we're also likely to see it coming in mental state at the time of the offense or sanity evaluations, as well as sentencing evaluations. Sentencing, including capital sentencing, that's an area where neuropsychology has had an increasing impact over time. In civil law, this is really where neuropsychology has its main impact on forensic practice historically. It has grown up in civil law related to not just competence, but also personal injury. Much fewer neuropsychological practitioners specialize in criminal work, and the contributions of neuropsychology to criminal law have been more recent in their development, but certainly both are well developed in the area now. Administrative law also a long time contribution of neuropsychology in workers' compensation and disability. Legal considerations continue to include admissibility standards as well. So we may understand admissibility standards in our forensic practice quite well. What about some of the tools and techniques that are going to be included in a potential neuropsychological evaluation? Do you have as much of a sense of, are those admissible in your jurisdiction or in the jurisdiction you'll be practicing in? That would be something to consider before you take on the case as well. There's also case law in the area, some overlapping with general forensic practice and some specific to neuropsychology. So the ability for a neuropsychologist to give an opinion about causation in brain injury had to be clarified by the courts. The flexible versus fixed battery approach had to be addressed by the courts. Madison v. Alabama is a really interesting recent example, one that's in our time very recently, that clarified dementia counting as a mental disease or defect that could be considered in competency evaluations. This case specifically was competency to be executed. So this is, again, just some of the case law that we would want to be familiar with, depending on the referral. Much of this should be familiar to us as forensic psychologists, and some of it won't be. So we would want to make sure to know the full scope of case law that is dictating our practice in these areas. Okay, so now you know what counts as neuropsychological considerations. But how much impact does it need to have? That would be the next question. Let's say the referral you're saying does have a neuropsychological consideration. The next question to ask would be, does it impact my forensic mental health assessment? This is really the core question that we would need to ask ourselves, and one that I think is worth a few examples. So if we are too broad in our understanding of impact, it may lead us to not take as many cases or preclude us from taking any cases that may actually be appropriate for us to take and evaluate independently or with consultation. If we're too narrow in our understanding of impact, however, then we may put ourselves at risk for taking on cases that are actually inappropriate for our experience and maybe we should be doing with consultation or referring out. So this is a real core issue, and one, again, that merits a little bit of further discussion here. So on the face of it, if the neuropsychological consideration that you've identified does not appear to be core to the referral question, or is very clear and well documented in the individual's history, they're unlikely to be core aspects to your evaluation. Either they won't necessarily impact how you go about conceptualizing the case, or you will be taking that prior well-documented history into consideration within your evaluation, but focusing on maybe the non-neuropsychological aspects because it's been so well characterized already, basically not being redundant over what's happened in the case up to this point. Let's assume that that's not the case though. Let's assume that the consideration you've highlighted appears core to the question and has not been fully elaborated up to this point. The focus would be on the intersection of the neuropsychological consideration and the forensic referral. And we're very used to speaking in terms of nexus, so I'll bring that term up now. At the nexus of the consideration and the referral, does it seem like this is going to play a large role in this evaluation? How you might determine that is really up to you based on your experience, and it's on a case-by-case basis. This is where your expertise comes into play. This is the hardest question to answer, one that you might seek consultation on to begin with. But let's take some examples. Let's say you get a referral and epilepsy appears to be the neuropsychological consideration. Within the referral documentation, there's some idea that this individual has a diagnosis of epilepsy. Well, if it's a chronic disorder with chronic symptoms And the psycholegal question is mental state at the time of the offense. And specifically, did this individual possess mental state at the time of the offense sufficient given that they have epilepsy? It is a core aspect. Well, that sure sounds like one that's a pretty large impact, right? However, if it is a history of epilepsy that is well controlled on medications, and the question is competence to stand trial, maybe not. I would probably want more information, right? But just kind of using these two examples as a foil, you can see one is much more core and central, one is much more to the side and may or may not actually impact your evaluation all that much. Dementia. Let's keep the disorder the same. So let's say recent onset of dementia symptoms. And let's change what the referral question is. A recent onset of dementia symptoms, and the referral is this person competent to stand trial? That's the question. That sure seems relevant. That sure seems central. Compared to mental state at the time of the offense, if the symptoms of dementia have started recently and the offense occurred years, decades ago, is dementia going to have an impact on your conceptualization of that case? Potentially, right? It would certainly impact your ability to gather information from the individual about their mental state. So it might change the structure of your evaluation. And depending what you find, it may be much more essential if you think that the dementia process was likely already starting back when the offense occurred as well. So again, keeping the onset of the same symptoms and changing the question, you can see that the case will really drive, the specifics of the case will really drive if you decide to take the case yourself or something else. Traumatic brain injury. A remote traumatic brain injury, let's say in childhood, does that have an impact on the person's competence to stand trial? Hard to tell. We would probably want to know a little bit more about the severity of that traumatic brain injury and other specific neuropsychological aspects of that injury to know, is it still impacting that person? Will it impact that person now and in the future? Mental state at the time of the offense, given a history of traumatic brain injury, we'd probably want to know when that TBI happened. Did it happen around the time of the offense? Could we say, given the severity of that TBI, they were still in the recovery phase when that offense occurred? That may be crucial in you deciding to take the case or not, depending on your level of comfort. So just a few examples, there's many, many more, but again, just emphasizing this is the kind of core question we need to ask ourselves is, given these considerations we've highlighted that appear to be neuropsychological in nature, are they actually going to impact this evaluation enough for me to consider taking it on my own, taking it with consultation, or referring it out? If you decide that, yes, it is going to have a significant impact, we then focus on ourselves. We've addressed that this case, this assessment appears to include a neuropsychological consideration that's impactful enough that we would want to think, do I have the appropriate level of competence, the requisite knowledge to address these things? This is not new. I don't think that this is going to be groundbreaking to anyone out there. This is well within the APA ethics code. This is well within the specialty guidelines for forensic psychology. This should not be new. Again, naming it and placing it within this context can be very useful in your daily life, in your daily practice, when you're thinking about these referrals and what you're going to do with them. So once you have highlighted these considerations, you then should consider your own training, your own experience. And based on that, if you believe you have the appropriate level of competence in that area, well, then you can take the case yourself independently, or you can do so consulting with a neuropsychologist or other allied health professional. If you don't feel that you have the appropriate level of competence, then we might continue in consultation with another expert that does have the requisite level of competence, or you may refer to that individual to take the case instead of you. The obvious question here is what counts as appropriate. And I can tell you certainly that the field of neuropsychology is explicit in what it considers competence, and they have spent a lot of time and effort making this publicly clear so that it's easy to tell ourselves if we have the requisite competence, as well as, let's say, the criminal justice system and opposing attorneys in helping to decide if we have the appropriate level of competence. So here I'd like to focus on a recent publication. This is from the Clinical Neuropsychology Synarchy. This is a organization made up of representatives of all of the major organizations in the field of neuropsychology in North America. This is an authoritative document, and part of this document includes a discussion of a taxonomy for education and training, as well as specific competencies that are kind of foundational to all of our training, as well as more specific to neuropsychology. So these foundational competencies, while again taking a lens of neuropsychological practice, you could pinpoint where a neuropsychologist gets this, but also these are areas of training that other psychologists have as well, and other allied mental health professionals. So kind of common across the training domains. The functional competencies are much more specific to neuropsychological practice in terms of assessment and consultation, research, teaching, management, and advocacy, everything listed here. And they break it down even further into knowledge-based and applied competencies. It can get overwhelming very quickly. The important thing here is that there is a very explicit guide from authoritative resources in neuropsychology, published where others can find it, that lay out what competency means. As a forensic practitioner, that should be telling you it's something that you might want to consider and know about yourself if you're interested in pursuing practice in this area. So the taxonomy is, again, based on an APA model, so it's likely to be familiar to us at least. And I'm less interested in having you read through all of this right now. Rather, I'm interested in you at least knowing that the structure exists and that the sources of training in neuropsychology come from doctoral training at the internship and postdoc level, and post-licensure as well. So being able to place ourselves on this taxonomy, at least being able to name what our level of competence in neuropsychological practice is, and communicating that to others is very helpful. And hopefully this table will be of help to those who want to review it further. At least it is letting us know if we want to call ourselves competent in this area. It takes a lot of training. It takes a lot of training, and it's because so many different areas are covered in neuropsychological practice. This is the knowledge-based competencies specific to assessment. Again, they do cover other areas where competencies or different areas of competency. These are the ones that are the knowledge-based competencies for those wanting to do assessment in neuropsychology. Reviewing these, you can see there are quite a few that are included, again, in all training. We all take biological bases of behavior if we come from APA accredited programs. Our training will likely include discussion of psychiatric disorders, for example, and the behavioral, cognitive, and emotional impairments of those disorders. We're likely to get training in methods of measurement and psychometrics, and across a few areas: cognitive and intellectual assessment, personality assessment, including all of these that are typically covered in an APA accredited program. So reading through this, however, there are areas that are typically not covered in all types of training, all areas of training. So knowing where you have gotten this information, this training, how well you feel that you've maintained that level of competency can be really helpful in making a determination of, am I going to take this case or not? Again, probably not groundbreaking here. That's not really the purpose. The purpose is to name and demonstrate what we're talking about when we talk about competence. Beyond these knowledge-based competencies, there are more applied competencies. Again, in our practice, these are things that would come up in the practice of taking on these referrals and doing these assessments, understanding, analyzing, and clarifying referral questions, gathering information through interviews, through testing, selecting and administering and scoring and interpreting tests, things that we're all trained in, but not necessarily in the same way or on the same tools as a neuropsychologist or someone who has more neuropsychological training than we do. Another big area is the communication of results. So something we all have training in. However, how you communicate neuropsychological findings requires a certain level of skill that may or may not have been included in your training to date. So these are a lot of areas that are typically covered. However, when we consider do we feel competent enough to take on this case ourselves? Do we want to have some consultation to figure that out? Do we want to refer out? These are the main areas that I would always consider in making those determinations. Hopefully it's helpful to you as well. This is a lot, not my favorite slide, not my favorite way of doing slides, but there's so much that goes into this. I do encourage you all to get that Smith et al. Article and review it yourself, and therefore be able to know that you are competent in these areas and capable of taking on this case, or you feel competent enough that you want to do it with some consultation from a knowledgeable other, or that you want to refer it out and know who you're going to be referring it out to. And so here we are back at our model. We have neuropsychological considerations that impact forensic mental health assessment. Do you have the appropriate level of competence? Those are the three questions you should be asking yourself in determining, do you take on the case yourself, take on the case consulting with others, or refer out? If you feel that you either do not have enough competence or want to have enough competence moving forward, right? Maybe you don't take the case this time, but you highlight this as an area that you want to grow your practice, and you may be looking out for how to increase and obtain additional competence in these areas. The next few slides are going to be for you. So start with what we know. This was a publication in 2003 on the principles-based approach to forensic mental health assessment that most of us have been trained on, and specifically applying them to neuropsychological assessment. This can be a really helpful publication for those who want to take our experience and put it within a neuropsychological context. This is something that is much more in our wheelhouse, and this publication is an exploration of how things we know can be applied to a new area for us potentially. It's one of those articles I wish I had written. Unfortunately, I was in high school at the time. Surveying the literature. If I had a limited budget and limited space on my shelf, these are the books that I would buy. The textbook of clinical neuropsychology came out a few years ago. It's edited by Morgan and Ricker, and it has incredibly detailed but easy to access chapters on specific disorders in clinical neuropsychology, as well as practical components to neuropsychological practice. Several chapters on forensic neuropsychology specifically are particularly helpful. If you want to focus a little bit more on forensic neuropsychology, the APA Handbook of Forensic Neuropsychology is a very good version. Again, chapters on very relevant and explicit topics written by area experts, certainly one that I think is worth our time. 2012 was a great year for the literature. Both Glenn Laraby's Forensic Neuropsychology, A Scientific Approach, and Kyle Boone's Clinical Practice of Forensic Neuropsychology came out. These work really well together. They actually are not redundant to one another, and they can shed some light on, again, this very specialized practice of forensic neuropsychology. Even if you don't want to be a forensic neuropsychologist, it can provide you with a lot of information of the disorders in neuropsychology through the lens of forensic practice. Very, very good reads. Much more recently, Karen Postal wrote this book, Testimony That Sticks. It is all about communicating neuropsychological evidence to stakeholders in the criminal justice system, based on interviews she did with many, many, many experts in the field, some that you will recognize, and put them, all of the suggestions and tips and recommendations they had, into one accessible package. So overall, if I wanted to know more and increase my competence in the clinical or practical or legal aspects here, these are the books that I would have on my shelves. In fact, my computer is being propped up by several of these right now. Also, a knowledge of the professional organizations will be very helpful. The 4 across the top are the main neuropsychological associations in North America right now. They all have memberships, conferences. There are great resources for further training in the field and practice of neuropsychology. NAV Neuro and No Neuropsychology are relatively recent additions that are focused on broad training in neuropsychology. Free, broad-based training. NAV Neuro is a podcast. No Neuropsychology is a Zoom-based weekly didactic series, quite similar to this one, all focused on specific areas of neuropsychology, including clinical disorders, practice areas, ethical considerations. Depending on how you learn best, either listening or viewing or reading, all of these together can be really helpful in bolstering your competence in these areas. Twitter is also great for neuropsychology. Academic Twitter is a very fertile area for neuropsychology. So just exploring neuropsychology or neuropsychologists on Twitter can be a nice way of seeing conversations in real time that the field is having. And don't forget the regional, state, and local organizations. They may have conferences or other training opportunities or special interest groups that may be really relevant to all of this as well. Again, please feel free to screenshot this. You will get the slides if you've registered for today, but I hope that you find these helpful. I also want to mention that all of these organizations that I've mentioned so far include member directories or ways that you can contact their members. So this can be really helpful if you are seeking consultation or to refer out. But it's a listing of the thousands of people around the country who want to work with you potentially. And keep in mind that there are going to be unaffiliated experts as well, those that aren't necessarily a National Academy of Neuropsychology member by you. But if you do a search and review their training, then it should be quite clear to you if they have the requisite competence and you might want to learn from. All of this is in the service of me wishing that our field and the field of neuropsychology interacted more. I think that we are allies. I think we have a lot to learn from one another. Much of today's talk has been about, as forensic practitioners, how neuropsychology can benefit us or maybe can provide a barrier to our practice in certain areas. But it is also the case that neuropsychological practitioners need to have the same level of competence in forensic matters. And they're going to be looking to us to learn those, right? So I think that increased interaction between our fields is an incredibly important way forward, both formal networking as well as just more formal conversations, joining these folks where they're having conversations, inviting them to join us where we're having ours. could be really helpful. And then informally as well. So these two folks are sitting 6 feet apart, wearing masks outdoors. They're being very safe. And they are having an informal conversation around what really interests them about forensic psychology and neuropsychology. And they're developing a relationship that can turn into a professional one. So consultation, referral, learning, it doesn't need to be formal always. So not something necessarily that we see too much of right now, but when we are able to connect, I do hope that our fields are able to interact a lot more and continue to learn from one another. So that's it. The learning objectives for today were to get a better sense of identifying neuropsychological considerations in forensic mental health assessments. That's mostly focused on relevance in our conversation around relevance. Describing general and specialty competencies in neuropsychological practice comes up with competence, and do we have the requisite level of competence to go in the direction that we want to for these referrals? And then selecting how to best respond to these referrals. This model based on relevance and competence, I hope, is a flexible, useful, practical model that you can incorporate. Ask yourself those few questions and determine if this is a case that you'd like to take yourself, consult with others, or refer out. These are the references for all of the background literature, as well as if you want to increase your competence. These are the full citations for those. Again, these will be included in the slides, and you will have these. And I'd like to end by just saying thank you to a few folks, to all my collaborators and colleagues at John Jay College of Criminal Justice. This is a picture of our campus that is allegedly still there. I have not independently verified that in some months, but we're looking to be back in Midtown Manhattan very soon. I'd also like to thank my collaborators at the Fortune Society, who provide reentry services for folks leaving New York prisons and coming back to the community in New York City. They do incredible work. Please check them out if you're interested in the area of diversion and reentry. The National Institutes of Health, specifically the National Institute of Neurological Disorders and Stroke, has funded my work, and I hope they continue to do so. They host a lot of very interesting and exciting work in the area of neuropsychology and brain health in general. Collaborators at Mount Sinai Brain Injury Research Center, again, if you're interested in this area, they have shown a very authentic interest in increasing access to the best science in brain health for folks with criminal justice involvement. And they've been very mindful in including those folks more and more in their programmatic research. And potentially you, anyone here could be a potential collaborator, and I hope that you do reach out if you find any of this work interesting. For example, I'm currently in the feasibility stage of a remote screening assessment tool to check in on people's brain healths. And it can be implemented in your agency or any agencies that you might be involved in. So if you think that sounds interesting, reach out, we can talk more about it. And stay connected in general. You can reach me by email. I'm on LinkedIn and I'm on Twitter. Please be kind when you go to my Twitter page. I just joined and I just got into the double digits of followers. So I'm hoping to be much more active there and continue this conversation at the intersection of brain behavior and law. So if this is an area that you're interested in, please see me there. And with that, we will transition into the question and answer phase.
Thank you so much. That was fantastic. For those of you that need your CEUs, the link has been posted. Just remember, please take a screenshot or print out the certificate. We don't mail them or email them to you. As for questions, what is your view on becoming board certified as a neuropsychologist if you want to work as a forensic neuropsychologist?
So board certification in neuropsychology is seen as the clearest way of demonstrating competence. It is not designed to be a requirement to practice in neuropsychology. So this question seems to be, so I want to work in this area. Do I need to be board certified to do so? And the answer to that is the same as with a board certification in forensic psychology. It's a way of communicating your competence very clearly to those. It can be very helpful if you're on the stand and being asked about your status as an expert in an area. And I think as long as you're able to know where your experience is and where it is coming from and communicate that to others, then board certification may or may not be a necessity. It's certainly not a requirement. So there is some movement in the area of who is certifying folks in forensic neuropsychology, and that's left to be decided. But I think that there's a way for there to be some flexibility in our personal decisions, and just make sure that if you do choose to work in the area, that you are able to know your competence and express that to others. And then the field will kind of help you decide if pursuing board certification in one or the other is worthwhile. If you find yourself frustrated, responding to that by pursuing more elevated certificates of competence may be worthwhile.
Thank you. So there's a few questions about sources. Of those that you listed, what would be your recommendation with regard to substance abuse, like the effects on brain and behavior?
Let's go back to that slide. I'm pausing because they're included in most. Boone and Postal, not so much, but any of the first three certainly do. Neuropsychology takes substance abuse disorders and problematic substance use very seriously, and it's such a foundational component to forensic practice that certainly it's handled in all of them. So I would say any of them could serve, and if you're more interested in it from a neuropsychological lens that you will add the forensic lens to, then the textbook of clinical neuropsychology would likely be your best bet. If you want it through the lens of both neuropsychology and forensic psychology at the same time, the APA handbook of forensic neuropsychology would likely be the best. It's also the most updated, so I would recommend it for that reason. There are also specific discussions of this in NAV Neuro. I don't know off the top of my head if no neuropsychology has addressed this. That's new as of this year, so they may just not have had the time to get to it, but please review the catalogs of NAV Neuro and no neuropsychology to see if they've been addressed there too by area experts.
What about books or publications that address neuropsychology specifically in regard to military personnel or veterans and post-traumatic stress? Do you know of anything there?
Same answer. So post-traumatic stress is on itself a very important area in neuropsychology. The experiences that can cause psychosocial trauma can also come along with physical injuries as well that sometimes get overlooked and can significantly impact daily functioning of those with PTSD. So it's going to be included in all these specific to military individuals. Not my area of expertise. I haven't gotten a lot of VA training, unfortunately. I will look into it, and if it's okay, I'll include a slide if I find any particularly good resources in that specific area. I would imagine, given the importance of PTSD and neuropsychology in military folk, that there would be a specific book on that topic. I'll see if I can find it and I'll include it in the final version of the slides, if that's okay, Dr. Bravka.
Of course, thank you. Okay, everyone, we are getting lots of feedback from you that we're having trouble with the CE link. We are doing our best to address that. So just give us a few minutes. You don't need to keep telling us. And we will continue on with questions. So let's see here. Why is dementia expected to increase so dramatically by 2050? Is it the population of elderly or something else?
So it depends on the context that you're focused on. Thanks for that question. In the general population, the average age of folks is increasing. So the population, as it is aging, it's kind of a larger population aging into the risk range for dementia. And in the criminal justice population specifically, policies in the 80s related to substance abuse created a particular, potentially is one of the reasons that the aging in the criminal justice population is such a large problem. So what we know from Bureau of Justice Statistics reports is that the elderly population, that's their term, the elderly population is the largest growing segment in their population. And it seems to include just the amount of people who, again, in the 80s kind of got involved in the criminal justice system still being there or being returned there because of violations. Also, the effects of incarceration on biological aging and cognitive aging are such that the definition of elderly in the criminal justice system and in the Bureau of Prisons specifically starts at 50, whereas in the general population, we tend to think of 65 and above as elderly. So there's a lot of reasons that this is likely to occur. It's going to be very important for us to figure it out very quickly. All of these are pre-COVID statistics, specifically within the criminal justice system. There has been a movement to decarceration because of COVID-19 and because the criminal justice system has been so hard hit. A publication just came out in the last week, I believe, in the Journal of the American Medical Association, specifically around decarceration and COVID-19. I suggest reading that if you're interested in kind of diversion and reentry and this as well.
Thank you. Do you know if there are any reliable qualitative differences in the nature of delusions and hallucinations in individuals with traumatic head injury versus schizophrenia or bipolar disorder?
I am not competent to answer that question. I'd want to think about that one and ask some area experts, including Bernice Markopoulos, Beth Arredondo, Crystalline Tussey, and Scott Bender. They've done a lot of work in neuropsychological profiles of folks with psychotic disorders. Looking into their work would probably give you the best answer to that. I'm not sure it will give you that fine grain differential analysis across those disorders though. So thanks for that thought-provoking question. I'm sorry I don't have an answer off the top of my head.
Can you provide an example of how someone with a diagnosed personality disorder would be considered for a neuropsychological consideration?
Yeah, so depending on the specific personality disorder, there have been patterns of neurocognitive weaknesses that are somewhat differential between them. So being a little bit more specific, a individual with antisocial personality disorder is potentially more likely to have executive functioning deficits than deficits in other areas. If executive dysfunction is a core consideration in that forensic referral, then you might consider it through a kind of neuropsychological lens. Schizotypal personality disorder has been shown to have more cognitive difficulties than the others kind of similar personality disorders like schizoid and the same. So if it's kind of a differential diagnosis question, then the neurocognitive profile may be helpful in determining that as well. So just kind of thinking about the cognitive symptoms, the neurocognitive symptoms that come with these disorders, and centering those in your evaluation, that would potentially bring it more into a neuropsychological realm than a general clinical psychological realm. Basically, how you're conceptualizing this diagnosis and what it means for that person's functioning would be the differentiating factor there.
Okay, it is just past 1 o'clock. So for those of you that need to go, you're welcome to hop off. In terms of the CEU link, if you are having issues, it should be up and running pretty quickly. Maybe try it in an hour or two. If you're still having issues, try it tomorrow or email us. It looks like Rachel's on. Did you want to add anything about that?
Yeah, no, just it should be working fine. I double checked it and submitted pressed a button. It should be working fine though.
Okay,
But
great.
reach out to me if they're having any issues.
Yeah, just go ahead and email us if you're still having problems with that. Okay, so the next question is, what is the state of rehabilitation for TBI, specifically with respect to damaged impulse control and frustration tolerance and aggressive behaviors?
Yes, so there have been very, very good meta reviews, Cochrane type reviews of this literature that are typically hosted by the American Congress of Rehabilitation Medicine, or ACRM. They are incredibly useful in determining what types of outcomes, specifically from TBI and stroke, are amenable to treatment and what treatments have the most evidence base to amend those. Given that the status of that literature, it does seem that for specific types of TBIs, those that are more likely to come with neurocognitive impairment because of the injury itself, so like a moderate to severe traumatic brain injury, that attention training and some other areas are amenable to attention and working memory are amenable to direct rehabilitation. I do want to mention that outside of direct rehabilitation, like rehabbing those abilities, you can train folks with accommodation strategies that will help them function in daily life and don't necessarily address the root symptom, but work around that symptom to still maintain functioning. So when we think of things like impulsivity or disinhibition, aggression, we may be talking about rehabilitation for some of those areas, but also providing other skills to allow folks to function better in their daily lives, even with those symptoms. I will say that's a big area of interest for mine. I suggest looking at the Brain Injury Research Center at Mount Sinai, who have manualized treatments for traumatic brain injury, cognitive behavioral based rehabilitation programs that are evidence-based and focus mostly on emotion dysregulation and executive function. So certainly they are out there, and that continues to be worked on. But that's kind of the state of the literature as I understand it.
Thank you. Before we go to the next question, somebody was asking about the references for the presentation and the PowerPoint slides. We do email those out. Give us about a week. And if you don't have that after a week, then go ahead and reach out to us and we'll make sure that we send it to you. But check your emails and check your spam boxes before you send us an email about that. Thank you. Okay, so the next question is, there were psychoanalysts like Theodore Reich who dealt with criminology and analysts like Alexander Luria who later embraced neuropsychology. There are various organizations that have practicing neuropsychoanalysts. Do you believe neuroanalysis is feasible in a forensic context?
I am not familiar enough with this literature to say one way or the other. I would say that how I always, and what I teach my students is, if there is a scientific literature to support the practice and the appropriate cultural responsivity and ethical considerations and practical considerations are addressed appropriately, then of course it can contribute. Anything can contribute if it is shown to have those foundations. I'm interested, thank you for that question. I'm interested to explore that history a little bit more, and be able to answer those sorts of questions better in the future. And for you and anyone else who has asked a question I haven't been able to answer well enough right now, or who we don't get to, please do reach out to me, and we can explore these things together.
Okay. The next question is, how would you think about collaborating with a behavior analyst?
So behavior analyst, I don't know if we can get clarification, but a general behavior analyst versus like an ABA, kind of autism focused behavior analyst, that the answer would be a little bit different. I would say that if we're talking more of like the ABA type, that certainly there are many good collaborations to be had there. Autism and other neurodevelopmental disorders certainly have a large presence in the forensic mental health field as well, not just for assessment, but also diversion and reentry considerations. So another field that I would think would be very welcome at the table when we're trying to address these problems. Without further clarification, though, I don't necessarily want to misanswer that question.
All right. Next individual says, I use the R bands as a screening instrument. Are there other screening instruments that you recommend for non-neuropsychologists?
Sure. Yeah, the R bands, that is a good one. Remember, all screening instruments are going to be sensitive, but not very specific. So the impairments you see may or may not represent weaknesses of that individual's abilities if they were to move ahead and do more comprehensive testing. So if you are in the practice setting, I think that the R bands is a good version. I particularly like it because there are multiple versions, and the requisite kind of reliable change psychometrics are there to really use that instrument in helpful ways. It's also available in Spanish, which helps its application. The Neuropsychological Assessment Battery, or NAB, has short forms of the different areas, and that could be used potentially. Depending on how much of a screen you want, you have the MOCA, or the mini mental state status evaluation. So MMSE and the MOCA are other options. The other ones that are kicking around my head, but I don't want to say, are much more experimental in nature and used for research. So I am particularly excited about the NIH Toolbox Cognition Battery. It's a iPad-based, rigorously developed screening measure of various cognitive abilities. Again, it is used in research. They do want it to be put into the clinical realm, but I don't think it's quite ready yet, and it doesn't quite have the status in the field. But yeah, I think the what you're doing right now is just fine. You may consider consulting with a neuropsychologist to develop a screening battery of kind of a similar type to what's included in the R bands, but maybe that each individual component has a little bit better psychometric ability to be able to get more specific about what you're able to say of individuals.
Okay, for those of you that were asking about substance use disorders, Dr. Atchison, who presented recently, suggested a book that he said was a little dated but very good. Allen and Woods, 2013, Neuropsychological Aspects of Substance Use Disorders, Evidence-Based Perspectives. And then for those of you that were asking about PTSD and veteran populations, someone suggested a book called Neuropsychological Practice with Veterans. And somebody else suggested I think, a link on the VA website, ptsd.va.gov/professional/consult. So those might be some resources for you.
Yeah, thank you for all those resources.
Yeah.
And
then
for your
another
presentation last week, Dr. Atchison, or 2 weeks ago.
That one was fascinating. Can you speak on working on collaborative evaluations in criminal cases needing both forensic and neuropsychological experts? And in parentheses, the person suggested Hilbrunner and Frumkin model.
Yep. Yeah, so this would be a more long-term consultation approach. So instead of an independent evaluation or completely referring out, you would be consulting in a team to approach these. It would be important to clarify the roles at the beginning and to make those clear, not just to yourselves, but also to the stakeholders in the criminal justice system. So it's clear what's happening. I personally think that that's a great model and one that could function really well if you are in an area with those resources. And to be clear, that would be someone who feels that they are more competent in neuropsychology, someone who feels they're more competent in forensic psychology, working together to either address the same legal question from different perspectives in different reports, or writing a report together that incorporates both of those, kind of using the peer review model as well. So I think that that's a great way forward, especially if you're in the type of practice that gets a lot of complex referrals. It would be a way of kind of checking your bases and making sure that you're always kind of on solid ground.
All right. I think we've got time for one more question because it is 15 minutes after, and I think this is a nice way to close. What changes and impacts from COVID, if any, do you foresee sticking around in neuropsych assessment?
Hey, Callie. Yeah, so this was, Dr. Atchison brought this up a few weeks ago. The types of difficulties being reported right now by these long haulers are quite similar to those being reported in the mild traumatic brain injury realm. So I see a lot of interaction or lessons to be learned there in terms of, so you have had this systemic illness that does appear to have neurological impairment in certain people. Having to demonstrate that neuroradiologically may be difficult. I think neuropsychology will have quite a role in defining and describing these problems moving forward. So if anything, it's creating a larger area of practice that already did exist. So this kind of systemic disorder and its impacts on forensic neuropsychology is an area already, one that certainly did not have quite as much focus on it until now, but I think it's going to impact our field for the foreseeable future.
Well, thank you so much for your time. This was fantastic. On behalf of the university and Behavioral Health Services, we're grateful and really, really appreciate it. Thank you.
Thank you all for being here.
Of course. So for those of you that are still on, we'll stay on for maybe another 5 minutes so that you can fill out that CEU link. Otherwise, we will see you next week. Thank you so much.
Thank you so much, Casey. Thanks, Carl.
Thank you.
Casey, you still on?
Yeah, I can stay on however long you need me.
Oh, no, well, I just wanted to say that was awesome. It was so good to see you present. I had a real quick question, actually. If So what might you do if you're in a situation where a neuropsych a strong neuropsych component becomes apparent like as you go through the evaluation. Like it wasn't maybe originally a part of the referral, but it becomes clear to you that it's influencing things. So you're sort of like past the point where you can turn it down at the outset and refer it out. And you're like, oh, your only option is to sort of consult, and it's sort of beyond your competency level. Like what do you think you might do in a situation like that?
So the model presented, I guess I should have been more explicit when I was saying flexible. That's kind of what I meant. And you can always restart, right? As you go through an evaluation, just like in a clinical evaluation, it may not be clear until a little bit later that there's this strong forensic implication, and you kind of have to reconceptualize. But I think as long as you are clear for yourself and what you're communicating to others about what you are doing and why, and then as things change to communicate that in the same way, then you can arrive at a final process that fits the needs of that evaluation. And so that model that I was saying, if another consideration came up, or if that consideration became stronger or more central, you could still think about it in the same way and take the same steps. I think that you would know pretty quickly if a neuropsychological consideration was so central that you needed consultation or to refer out. In that way, potentially the consultation relationship would be much more writing a report together with someone or writing separate reports that are both addressing the same thing. So the Heilbronner-Frumkin model is a good one there. But yeah, I mean, that's why it's helpful to have these relationships already so that you can go to those individuals and ask them, rather than the introduction being like, hey, I'm in the middle of a really complicated case and I'm hoping you can help me out, and the report is due tomorrow. So that kind of informal networking at the get-go, just to kind of have these folks available to bounce these questions off, would be really helpful. You have me, you can always reach out to me. Anyone still on can always reach out if you have these sorts of questions, but I recommend finding your friendly neighborhood neuropsychologist to do so as well.
Sounds good. Thank you.
Yeah.
Okay, I think we're going to adjourn the lecture today. Thanks so much again, Casey.
Thank you. It was very good seeing you.
Yeah, it's good to see you too. If anybody has any questions regarding the CEU link, you can always email us and we're happy to help. So thanks, Anthony. I'll see you later.
Bye, everyone.
Bye-bye.